to start you off. So to begin here, we're going to try to do a digital version of our radiology rotation for all of you guys. So this will be a new thing for all of us trying to do the new virtual 2020 COVID radiology rotation here at the University of Utah. As Dr. Olpin mentioned, we're going to try to record all of these lectures. We know a lot of you have variable schedules, so we'll try to record them and make it available to you so that you can watch it somewhere. We'll probably start a YouTube channel or something like that just for you guys to set up so you can watch it if you miss some of the talks. Some of the lectures, we'll try to intersperse some quizzes either throughout the lecture or at the end of it. We'll try to send you an email beforehand about those. And we'll obviously, this is all new to all of us, so we're going to be a little bit lax clearly with all of this, but we'll try to go through and put together some good content for you. There are some notes and quizzes and cases that are available at Canvas, and we've tried to put together a great lecture series for you guys over the next couple of weeks with some great speakers from all these different radiology areas. So I'm going to give kind of an introduction to radiology or an orientation to the radiology department itself and radiology as a specialty during this. So we'll be talking about radiology and all these aspects. I have nothing to disclose. I don't own radiology. I don't make money if you buy radiology equipment. So a big part of this is the history kind of imaging modalities and how all these modalities came into being and the basics of how they work. So I'm going to start off today with kind of a big overview orientation to all of radiology, and we'll look at all these different specialties and the technology that we use, and a little bit about when they're good to use actually for your patients on the clinical service. So we'll talk about plain film and CT and fluoro, angio, and all the cross-sectional imaging modalities that are very popular and we use a lot in our daily world here in radiology. And there are a lot of specialty areas in radiology, and it's very different for us in academic than it is for the guys in private practice. When I was in a little bit of time I spent in private practice, you're trying to do all of these at the same time. And it turns out it's hard to know everything about everything. So we tend to specialize in academia. So we have people who just do neuro, maybe brain, spine, and head and neck, people who just do cardiothoracic, people who only do ultrasound, people who do MSK, working with joints and bones. There's a lot of specialization that we see in radiology. And this is a relatively new specialty, actually. So William Roentgen in 1895 is credited with starting really radiology itself. And he was doing some very basic lab work with a vacuum tube and some fluorescent screens. And he noticed that this fluorescent screen would start to glow on the other side of his room every time he turned on this vacuum tube. And he didn't know what kind of rays were going from the vacuum tube to the fluorescent screen. But he noticed that after he would turn off the vacuum tube, the fluorescent screen would stop glowing as much. And it kind of freaked him out. He locked himself in his lab for a couple of days, wouldn't let anyone in and out. He couldn't figure out what was going between those two devices, and he called them X-rays. And that's exactly what we still use today. We still call it the same thing. And we think about this as an electromagnetic radiation. It has high energy and short wavelength. And the basic ideas of what he was doing way back then, 100 years ago, is the same thing that we're doing now. So this is Roentgen, and one of the first X-rays is, depending on what you read, either his hand or his wife's hand. And this is actually a picture of him in his lab. And this was 1895, and he won the first Nobel Prize in Physics in 1901 for his work with these vacuum tubes and with fluorescent screens. So he just happened to have two research projects going on at the same time. And the fluorescent screen he was using on a different project, he noticed would glow every time he turned on this vacuum tube. And that's how radiology was born. And that's the same idea now as what he was doing back then. So we have a radiation that's going through an object that exposes an X-ray film, and that's how we generate a radiologic image. And this was quickly found as a brand new thing. A wonderful new X-ray can see through your hand. And people were taking X-rays of all kind of different things. It's used in artwork and still promoted in that same way in artwork now as it was 100 years ago. And actually, amazingly, it wasn't that long ago that even shoe sales places would have this Buster Brown shoe thing. So you would stand up here with your shoes on, and it would look at where the end of your shoes, and the salesman and your mom could look in the X-ray machine and actually see where the shoes were fitting. And believe it or not, it wasn't until about the 1960s and 70s that people decided this was not a good idea. People are radiating their toes like crazy, and this was actually stopped. So this was a routine thing, believe it or not, back in the 60s and the early 70s, shoe fitting data. So they had an idea of what they thought the right way and the wrong way shoes would fit. And you could put on your shoes and put them in this x-ray machine and people would look at. And people were just irradiating themselves all the time in this way. It was thought to be a really neat thing. You could see through your skin. And we have some idea of where we think about X-rays living on that spectrum in terms of visible light. And if you think about everything you're constantly being exposed to, radio waves, microwaves, Bluetooth, Wi-Fi, everything else, X-rays is way over here on the spectrum. What you can see as visible light is a very small part of the spectrum of everything you're being exposed to. But what we do now is the same as what he was doing then. We have an X-ray source that goes through an object, usually a patient, and then it exposes a film that we get our actual X-ray from. And it wasn't that long ago here when I came to Utah in the 90s. This was our X-ray machine processing thing. And we would take that cartridge and put it in here, and it would go through all these rollers and dip into different fluids. It was the exact same thing we used to process 35 millimeter film if you were taking pictures back then with a camera, and the image would come out. And that's how we originally got the naming for a wet read. If you took out the film and you needed to know immediately what it was, you would hang it up. And while it was still wet, you would try to give somebody an idea of what was going on in the image. And that's how we got the name for a wet read in radiology, if you need something read very quickly. And we still think about it the same way now. And it's a little bit odd. And this was a big argument when we first started radiology, where we're looking at densities of stuff. So air is not dense, so that's black. Bone is very dense, so that's white. Everything else is kind of in between. But the odd thing is when you're looking at the image, you always think about shaking the patient's hand. So the right is kind of on the opposite side of what you might think. And believe it or not, this was a big argument with the surgeons, which side the right should be on when we actually look at it. But the idea is anytime you look at an x-ray, you think about looking at the patient. So if you shake that patient's hand, their right is going to be over there on the opposite side. So we can look at that and get an idea of where the heart silhouette is in the middle and where the right lung is and where the left lung is. And we can see these borders around everything on the chest x-ray where there's a margin between something that's soft tissue like the heart and where there's something that's air-filled like the sponge that is the lung. Then you see a nice border between those two structures. So here on this study, you can see how we've kind of lost that sharp border. You can see the border of the heart on this side, and it's fuzzy on this side. So that might make us think there's pneumonia or something else. So we're looking at densities of stuff when we're looking at these chest x-rays and trying to figure those out as we go through. And we think about all these different densities all the time. Now, one thing is if you have a single view, it's a little hard to tell exactly what's going on in that image. So if we have a single view of the abdomen, I don't actually know if all this is in the abdomen or if it's in the front or behind. Is the patient laying on top of it? I can see outlines of big buttons here. I'm assuming those are on the patient's clothes. I can see some contrast in the distal colon. Here's a tube that might be going up to a pelvic kidney. I see a bunch of coils that are probably in arteries. Big safety pin that's probably outside the patient. Here's a Jackson Pratt grenade drain, suction drain. Here we see a surgical clip. So we're looking at all these densities all the time on imaging. So that's what we're thinking about all the time in radiology is all these densities. And we actually have films up. We used to have films like this up. This was at the VA. So anytime we were thinking about things that might be retained inside the patient, we would have a comparison, like a control, to see what that should look like. So if somebody's doing an operation and their needle count is off, we might go look at this and see what needles look like on x-rays, and we would compare that to the x-ray of the patient to see if that looks like what we're looking at. So we have some idea of the densities of all these different things that we use normally in medicine to try to figure out if they're in the wrong place at the wrong time. So one of the other things we're thinking about all the time is data. So everything's digital now. So we're looking at all these on computers. So all the images that we talk about have a spatial resolution. Say there's 2,000 dots across and 2,500 up and down. So 2,000 dots across and 2,500 dots up and down. And we have a contrast resolution, how much data is attributable to each of those dots. So we get an idea of how much data an image is. So a chest x-ray might be 10 megabytes in size. So we're generating a huge amount of data. The hospital generates 50 terabytes of data or so a year. And we're always thinking about that with our storage solutions and how much data we're sending around the hospital. And in reality, the radiology department right now may generate more data in a day than the rest of the hospital in a year. And that's the same basic idea for everything. So for example, mammography, we have something that's generating x-ray. It goes through a body part and it exposes film and goes through. A digital mammo, though, is much higher resolution. So those images might be bigger, might be 40, 60, might be 80 megabytes for each image. If there are 8 images, you can see how that would add up to a huge amount of data very quickly. So just mammography itself, if you combine all the mammography being done across the US, it's suddenly petabytes of data. It's a huge amount of data very quickly. And that is the same idea of what we're doing now. We have something generating x-rays. We have a buckyboard, the film cartridge that may move up and down the table, and we put the patient on here and scan them. And there are some rooms where we can move all these pieces around, something that's generating x-rays, something that's detecting, so we can have the patient stand up or lay down, and we have that same piece of film that's exposed digitally, so we immediately generate a digital image, so we don't have to process that film anymore kind of when we're doing this. And we can position the patient in whatever way we want, and we have that device that's generating x-rays that will irradiate the patient for us. And we can do fluoroscopy. So we can have the patient stand in front of that unit and move around. So here's a patient flexing their neck. So here's their chin, there's a mandible, there's a maxilla, here's a cervical spine. And you can see the relationship of all those vertebral bodies and their facets as they move in relationship to each other. And you see all the facets of the spine and they generate. As this patient flexes and extends their neck back and forth, you see how all those vertebral bodies shift. So here's a lateral fluoro view, and the patient's turning their head now from right to left. And again, you get an idea of these vertebral bodies and the spinous processes here. Here's all the pedicles out laterally, how the vertebral bodies all shift in relationship to each other as they go back and forth. So that's fluoroscopy. Now we can also, somebody came up with a great idea. Hey, wouldn't it be neat if somebody could swallow something and we could see inside the body, but it didn't kill them? That would be neat. So here we have the patient swallow barium. So now we see contrast. So here's the spine, just like we saw in that fluoroscopy, but now the patient's drinking contrast. So we can see this very dark contrast going in the oral cavity and oral pharynx, and here down into the hypopharynx behind the larynx. And we can actually fill out all those areas as the patient swallows. The epiglottis closes over the larynx, that's the tube above the trachea, and we see the contrast go from the hypopharynx down to the esophagus here at this level. And you have a little bit of contrast staining that nicely outlines the airway. So if somebody has a swallowing problem, we can have them swallow contrast to see that. And you can see the piriform sinuses here and the epiglottis, and you see all these structures very nicely outlined with a swallow study. So we can follow that contrast down the esophagus, so all the way down here behind the heart. And if we follow the patient with a little bit of air, then we sometimes see these structures even better. So as they swallow, that epiglottis closes off and we block the esophagus as it goes down, and then we have contractions that go down the esophagus as the patient swallows and moves that contrast. Now, another idea is to have the patient drink fizzies. So what we used to do is we'd have the patient with 2 cups and we'd drop these little fizzies like old Pop Rocks candy in one. So we'd have them kind of throw back the Pop Rocks like a shot and then drink the barium. If you imagine kind of blowing up a balloon and then putting contrast in it and rolling it around. So this is an air contrast swallow study where we can see we dilate up the esophagus and we line that mucosal surface very well here. And we can follow that down to the GE junction. So if there's a big hiatal hernia, we'll see that here, down to the stomach of itself. And we see very nicely the lining of the stomach, all those rugae, the mucosal folds. So we can evaluate if there's a big ulcer here in the stomach. That's something that you can see with this kind of study. And we can follow that all the way through. So here's that pylorus, here's a C-loop of the duodenum, and you see that mucosal surface looks very different than what we see in the stomach, and all the lining inside the GI tract as you go through the small bowel and the large bowel, that mucosal surface looks a little bit different, so we can evaluate that differently as the patient swallows. And we could, if we want, put a big tube through. So here we put a tube through the GE junction, through the stomach, through the pylorus, around the duodenum, and we can inject contrast very quickly into the small bowel. and we can dilate up that small bowel and see those mucosal folds very nicely with this study. So we used to do a lot of these. We don't do them as often now, but we'll hear a little bit more about that in the next couple of weeks from some other speakers. And you can follow that contrast all the way through the small bowel, and we can push the bowel out of the way and dilate it up very nicely. So if there's a stricture somewhere, we'll see that, and follow it all the way through down to the large bowel at the very end of the small bowel and see that connection. And we can also do the same thing, fill up people from below. So we can plug up from below through the anus and put in contrast and then puff in air. And you can see this air contrast barium enema study where we see very nicely, we dilate up the loops of bowel and we see that mucosal surface very nicely here. So this is an air contrast barium enema study. And we can have the patient lie down on one side and all the contrast you see is gravity dependent goes there. So you see how well, though, we see the mucosal surface of the bowel when we do the study. And the same thing as the rectum here, we've dilated up the rectum and we have contrast here. So the patient's laying down on their stomach and we're taking a lateral view. Here's the sacrum in the back and here's all that bowel. This is a deficogramgram. We can actually inject contrast in the rectum and then have the patient sit down on a radiolucent toilet and go to the bathroom. We can actually evaluate the levator ani, the floor of the pelvis musculature, and for patients who maybe having encopresis, whatever the problem is, we can actually watch them defecate and see how that musculature is working. So it's a very interesting way to actually evaluate that musculature that you could imagine would be very hard to evaluate on different methods. And we can fill up the bladder. So if we put in a Foley, blow up the balloon there and inject contrast in, we can see the bladder very nicely here. So if we had reflux back up the ureters, we would see that very nicely here on this study. And we can cannulate the cervical os and fill up the uterus, see spillage both sides and the tubes. And if we see spillage on both sides, that may be a good thing to do a workup for a woman patient who's having infertility problems. If there's didelphian or bifid uterus, if we don't have spillage on both sides, that's something we can evaluate this way. Now this is an IVP study. So basically, if you have a hole, we can put contrast in it and take pictures of it. Imagine that. So this is an IVP study. So we can inject intravenously with contrast. So at some point, somebody came up with a great idea. Hey, wouldn't it be neat if we could inject contrast in a blood vessel or gives it IV that would show up on x-rays but not kill the patient? That would be cool. So here we did an IVP study where we injected contrast intravenously and we can see the outline of the kidneys. We see the pelvises, the ureters going down to the bladder. And you see here, this is a 10 minutes. So we used to take these x-rays over and over again to see contrast going all the way down through those ureters to the bladder. So, hey, that would be really great if we could put a catheter in somebody and inject a material that didn't kill them, but we could see on x-rays. That was the origins of angiography. And you see, that was in the 1920s. So that really wasn't that long ago. So Roentgen won the Nobel Prize in 1901. He invented kind of x-rays in 1895. In the early 1900s, there were actually already radiology studies sprouting up, radiology societies sprouting up around Europe. So this evolved very quickly. So angiography really kind of took off in about the 1920s. People would put a needle. We could do direct sticks in the carotid. We did direct sticks in the aorta to do runoff studies. And we would get these images where you could see the inside of the blood vessels. That was a huge deal for us. So this is a angiogram I did back in the 90s. So we would put a catheter up in the carotid and we would inject. But you see how hard it is. This is a case of somebody who had a vascular pathology. So the arteries and the veins were connecting. So you can see this weird connection of blood vessels. But you can see how hard it is to see like through the temporal bone, densest bone in the body. So we could see the arteries going up, but it was a little hard to see sometimes around the bones and everywhere else. Well, when you digitize everything, this is an image taken of a plain film, kind of cut film x-ray. What if we could take an x-ray of the head and tell the computer, hey, ignore everything you just took an x-ray of and only show me the new things like blood vessels that show up. This is a similar lateral view. This is the temporal bone, but you see how that all disappears. So this is the idea of DSA, digital subtraction angiography. We tell the computer, take an x-ray and then ignore everything you just took an x-ray of and only show me the new stuff. So you see with a DSA how much better we see the blood vessels going up into the head. That was a big shift for us doing angiography studies, going from plain old catheter angiograms to DSA, digital subtraction angiography. That was a big deal. So we can put a catheter pretty much anywhere and inject contrast and see that contrast going out through blood vessels. So this is a run of an angiogram. And again, this is a DSA, so you can kind of faintly see where the spine is, where the spinous processes are as the patient moves a little. Here's the bowels showing up as the patient moves. But we tell the computer, ignore everything you just took an x-ray of and just show us the new thing. So this is a DSA study, and we can see that staining very well. So if you want to see the inside of blood vessels, that's great for this. Now, people started to get the idea, hey, what if we could do more stuff through that catheter? And then we had all of these stents and balloons and neat things that we could do. So if somebody had, say, a fatty plaque and somebody wanted to open up that blood vessel, we could put a balloon over a catheter, over the wire, and blow up the balloon. Maybe that would help keep that blood vessel open so more blood is going through. And you know what might even be better? What if we had a stent and we could blow up that stent over the balloon? So there's interventional radiologists who do work in the body, and usually neuro is a separate department in most academic sites. So neuro IR is different than body IR, but you can put a stent in to cover up. So this is a big thing for interventional radiology, how we can treat our patients differently. So say you're a neurosurgeon, you're thinking about cutting open the brain to get to some aneurysm that's deep in the brain and trying to do that. So if you have an aneurysm in your head, one option is to go to neurosurgery. And you can have your head shaved and you put a tube down your throat and a couple days in the ICU and they dig down through your brain. Hopefully they put it back in the right place. And you spend a couple days in the ICU and maybe another week in the hospital, then you go home. Or you could have an angio work. What if I could take a catheter with a wire and put that way up into the head and to the aneurysm? And then I push these little wires out into the aneurysm. So I just make a little tiny nick. It's just a couple of, maybe an inch on your leg, just a couple of centimeters. I would put this wire up in your aneurysm, and we would actually inject these little coils up into the aneurysm. And the interesting thing about these coils is that when they are exposed to blood, they start to swell and they block off the aneurysm. And the aneurysm is essentially just blocked off on its own, kind of like cement enclosed aneurysm. So the blood vessel under it is totally fine. So I might do that. I might make a little tiny nick on your leg and maybe watch you in the hospital for a couple hours and then you go home. That's very different than spending a week or so in the surgery and having somebody dig down through your brain. Well, what about the spine? We do a lot of fusions in some places where they put big screws in the vertebral bodies. So you have the vertebral bodies and the discs and all the nerve roots coming on. If you have some kind of trauma or osteoporosis, you lose density, you could do a huge fusion where you put in big screws. But what if you could just inject cement just in that one place? Imagine just taking a needle, putting it in the vertebral body, and then taking some kind of cement and injecting it into that vertebral body itself to either bulk up the vertebral body, maybe you get a little bit of height back, but if nothing else, you at least cement that vertebral body so that you don't have more height loss. That would be a big deal. So that's another example of an interventional procedure, a vertebroplasty or a kyphoplasty, where we can inject cement in a vertebral body to help patients who have trauma fractures or osteoporotic fractures that are losing height. So interventional is a big thing, and it comes kind of in different flavors. One is we work with the GI guys. So if they do an EGD scope, they put a scope down through the stomach around the C-loop of the duodenum, they cannulate the bile duct, and they can inject contrast in. So we can see if there's ductal dilatation inside the liver and see what the biliary duct looks like in that case. If they think somebody has retained stones, this guy's got a bunch of surgical clips and the gallbladder fossa, so maybe he already had his gallbladder removed. If they think he has stones that are retained in the bile duct somewhere, we can do this study to do that. So here we're injecting contrast in that biliary ductal system. And we can change the images. So you can manipulate the images in a lot of ways on a PACS system, Picture Archival and Communication System, PACS. Those are the computers that we look at. So normally air is dark and metal is bright, but we can flip it if we wanted to. Sometimes that helps us see threads. For example, if there's a screw fracture or if a total knee prosthesis like this is out of place or something is loose, we might see it better if we flip the image. So we can do a lot more manipulating the image on PACS than we can normally. So there was another huge shift in radiology in the 70s. So we had the onset kind of CT and MRI, our big cross-sectional imaging modalities that we use a lot. So the original Hounsfield, the guy we like to name stuff after in medicine, the original CT scanner was kind of like a big water bath. You would just stick your head in this water bath. And it was very slow to get the images, but that's the origin of CT. So that's pretty new. We think about these are really just being in the last 50 years or so. So in 74, this is one of the first head CTs. You see how rough that looks. And it actually took hours to just acquire a slice. And you didn't see any images for a couple of days afterwards. So you get an idea of how fast it is now that we instantaneously see all these images. Sir Godfrey Hounsfield is what we named this. And the interesting thing about CT scanners, we can think about a CT scanner as just a big, stupid densometer. We're looking at densities of stuff. And the very interesting thing is that they're all standardized. So if you have a CT in Japan, or if you have it done here, the densities are going to be the same. Everybody sets it up so that water is 0. Bone is about 1,000. Air is like a -1,000. We have some idea what soft tissues are. For fat, it's always going to be -40 to -100. Those densities are going to be the same on every CT. So a CT scanner is a big, stupid densometer. It's just looking at densities of stuff. So just like that X-ray we looked at, air is dark, that's black, bone is white, it's very dense, everything else is in between. But we can get an idea of what is soft tissue, what is fat, what is fluid, the stool here, the contrast, air fluid level. We see all these different densities on our studies. So we have, just like the X-ray, we have something that's making an X-ray and we have something that's detecting the X-ray. And with the CT scanner, this would spin around the patient and do X-rays in a circle over and over again. So this is what one of those looks like, our CT scanner that we had years ago over by the ER. It was just a big tube, and we would put the patient in the middle, and it would take an X-ray in a circle over and over again around the patient. And we got these pictures that showed us that anatomy very well. So we could look at different windows. We could look at kind of a bone window where we see the bones better, something like a lung window if we wanted to see air. We have different soft tissue windows if we want to see fat, or if we want to see the gray-white junction in the brain, we can see that best here. So we have these different windows we can use. So then we got up with the idea of spiral CT scanner as our computers got smarter. What if we could move the patient through the scanner while we kept doing the X-ray in a circle over and over again? So originally, we would do one circle, and then we would move the patient. Then we do another circle. Then we'd move the patient. Then we do another circle. So a spiral CT scanner, we're moving the patient while we're doing the circle X-rays over and over again. So we have detector rows. So these are the actual detectors inside of CT scanners. And if you just counted these, that would tell you the slice it is. So if you hear people talk about this is a 24 slice, a 16 slice, a 128 slice CT scanner, that's what these are. So if I counted these little dots, 1, 2, 3, 4, 5, 6, 7, 8, 9, if there were 16 dots, then I know that that's a 16 slice CT scanner. So this is the inside of that CT scanner at that level. So something is generating X-rays, something's detecting X-rays, and we're spinning this around very fast. And you see how quickly this actually spins around all the time. And you see why this is closed, because we're asking the patient to voluntarily put part of their body in the middle of that hole. This is a big thing for a CT. So this is a CT scanner. So here we have a plain film X-ray. So when we do a CT, we start off with a scout. So we do a scout X-ray and we tell the scanner, I want you to scan from here to here and show me this anatomy that's there at that level. So we start off with a plain X-ray when we do a CT scanner. And here's an axial cross-section through the body. And again, we're just looking at densities. So air is not dense, so that's black. We have a lot of soft tissue. Here's a gallbladder, here's a liver. Here's some contrast that the patient drank. Here's some air in the bowel. We see the vertebral bodies are very bright. They're very dense. We see the fat here. And again, we can measure this. If I measure this here at this level, and this is -100, I know that that is fat. And again, it doesn't matter if that CT was done here or if it was done in France, everything is standardized. So that's a very powerful tool for us in the radiology world. And we can give contrast. Here we give contrast. We see how the kidneys light up. We see the blood vessels going to the kidney. So here's the aorta, here's the IVC, here's the renal vein. So we have contrasted blood from the kidney that's coming back and mixing with the non-contrasted blood in the IVC. We can see some contrast that the patient drank. We can see air in the bowel. We can see this fat. We can see the liver. We see these areas of low density in the liver. So on CT scans, we're talking about density. Is something high density? Is it low density? Is it enhancing? Those are discussions we have with this. And again, it's a very powerful tool because they're all standardized. So here's a lower cut down at the pelvis. So again, we see the bones of the pelvis. We see the contrast the patient drank. We see stool. We see fat. We see muscle density. We see all these different densities on a CT. Here's an unfortunate patient had a pancreatic adenocarcinoma, and we were tapping her and getting fluid off every day, all those massive ascites. So you see an open wound here. If we're trying to close something by tertiary intention, we don't see the bandages very well, the packing material, but here's some free fluid. Here's an air fluid level. Nature abhors straight lines. There's not a lot of straight lines in the human body. So anytime we see a straight line, we think about either an air fluid level or a fluid level in that case. So we see here all this fluid density that should not be there outside of the bowel. So again, X-rays, very interestingly, and again, this was a huge argument when we started doing CT and MRI scans with the surgeons, because as you can imagine, the surgeons were already so mad because the right was always on the opposite side to them. But it turned out the radiologists were in control of the CT scanners and the MRI scanners, so we actually think about it the same way. We think about kind of shaking that patient's hand, or if the patient's feet were towards us and their head was away in cross-section. So we get an idea of where the heart is in the middle. We have the right lung, so that's going to be the right side. Again, it seems like it's off, but you think about shaking that patient's hand, so that's his right, and that's the left lung when we think about imaging. So we use that same standard as with chest X-rays as we do with CTs of the chest in that sense. So we can do the same thing in the brain. So here's a head CT. We see some fluid that's around the brain parenchyma itself. The bone is very dense, so it's white. Air is not dense, so that's black around the outside. So again, if we were doing the cervical spine of a CT, for example, we would start off with a scout, a plain X-ray, and we would tell the computer, I want you to get scans from here to here, and scan very thin sections through that area. And we would get these very nice sections that we can do different formats. So here's a sagittal reconstruction, so we can see the facets of the cervical spine, how they're all aligned at that level. Here's a coronal reconstruction, so we see the tip of the dens, we see the lateral mass of C1. So as you can imagine, a patient who may have had a bad car accident, we're worried about a fracture, we're going to see the bones very nicely and very quickly here. So the occipital bone, the lateral mass of C1, here's C2 vertebral body, here's the den. We'll see this relationship very nicely here on these images as we go down through the cervical spine. So we can do the same thing if we want to see the cervical soft tissues. We tell the computer, I want you to scan from here to here and give me very thin sections, and we can see all these soft tissues. So we see the bone is very dense, we see the air, we see all these soft tissues. Now in the cervical soft tissues, we have a lot of little parts, so it can get very confusing, but we see all these pathologic lymph nodes in the neck, and this patient had a cancer here of their supraglottic larynx. And we can take that data set and reconstruct it. So we think now about acquiring a data set and then reconstructing it in a lot of different ways. So we can do very nice coronal reconstructions where we see all these lymph nodes on both sides of the neck, and we can get sagittal reconstructions. So here's a sagittal view. So we talk a lot about axial, coronal, and sagittal views, and we can do all kind of oblique views through the body. Now, as you can imagine, dental amalgam is always a problem for us. We have a lot of streak artifact from all this metal in the teeth, so you kind of lose all of that area. You can take that same data set without actually giving more radiation and reconstruct it in a different plane. So instead of getting this, where it's very hard to see the tongue and that musculature, you may get a picture like this. We didn't have to give the patient more radiation here. We just reconstructed the data. So that brings up the idea of data reconstruction and all our different manipulations that we can do. So we can reconstruct the data in all kinds of different ways to give us a better idea of that anatomy where the kidneys are and the aorta going down and the bones, and make different colors so that we can see this anatomy. It's very good for pre-procedure planning as well as patient education. So you can imagine manipulating something that's very complicated, like all the carpal bones that are in the wrist and how they articulate with each other. This is my wrist I scanned a long time ago. We can do the blood vessels. So we inject contrast. If we take away all the soft tissues, we see the common carotid artery here very nicely. Here's the external and the internal. We can follow those up very nicely. Here's the vertebral arteries. So we can make very nice pictures very quickly with these modern CT scanners. Or you can take away all the soft tissues and the bones and just show the airway. So here we see the upper digestive tract. Here's the epiglottis, the piriform sinuses going down to the trachea. And trauma is a big thing for CT. So if we think somebody has trauma, like this gunshot wound, with plain film, you can only see so much. And we know that plain film is not very good for some things like fractures, evaluating sinus disease and things like that. So I can see a lateral view here, and I can see an endotracheal tube and maybe a nasogastric tube that are going down. But it's very hard to see all the pieces of this bone on just a plain film X-ray. If I do a CT, you get a much better idea of where these pieces of bones are and exactly where all these pellets are, for example, in this case. And I can do all kind of reconstruction. So here's kind of a panorex, a curved reconstruction of the mandible. So I can see all these pieces of the mandible and think about how we might try to put them back together. And we can do all kind of surface rendering, 3D MPR manipulations, multiplanar reformations, to get an idea of exactly where all these fracture fragments are. So again, we acquire one big data set and then we can reconstruct it in a lot of different ways. Some things seem pretty obvious, that may be a lot harder to tell exactly what's going on in depth. So this is a plain film X-ray. This is a big knife that's going right in to the skull, a Leatherman tool with that blade. It's going right in. So on plain film, how much can I tell you about exactly where this tip is? I don't know if it's on one side or the other or anywhere else, but if I do a CT, I can see exactly where the tip of that knife is. So we can take that data set and do all kind of reconstructions to think about exactly where the tip of that Leatherman is, for example, in this case, and think about best methods for trying to help this patient. Do we immediately just take this out? What anatomy is affected deep to it? How deep is it going in? Everything else. So with imaging here and these reconstructions, we can help the surgeons think about therapy and how they're going to care for that patient. So here's a CT examination on lung windows, and we can see these diffuse mets on this unfortunate patient who had adenocarcinoma. And instead of just seeing big dark sponges, we can see this metastatic disease. And so CT is a very powerful tool to very quickly get a view of that anatomy and see if there's a rough pathology anywhere. Now, it's also very important in density. So again, this is a big densometer, so density is a huge deal. So here, for example, in this temporal bone CT, this is an axial CT, I see these permeative destructive changes, so I'm losing bone. Now, this is a particular area of the jugular foramen, and I know that if I have a permeative destructive lesion, I know what that pathology is. That's a paraganglioma. And I know if a patient has sclerotic increased density, that's a meningioma. And if a patient has smooth scallop margins, that's a schwannoma. So this is a complicated anatomy area and a complicated pathologies. But it's very interesting. If I have pathology at a certain area, if I see decreased density, I know what that pathology is. If I see increased density, I know what that pathology is. And if I see smooth scallop margins, I can tell you what that is. So this is an area where if I have a well-done CT, I can tell you exactly what the pathology is before you even do a biopsy. That's a very powerful tool for us. So next we have MRI. So a cross-sectional imaging study, and again, pretty much just the last 50 years or so. This is an intense uniform magnetic field. So instead of just a donut like a CT scanner, this is a long tube. So on the plus side, humans are about 70% water, and the Earth is covered with about 70% water. So that worked out well for us. But we can put your body in the tube and then apply radiofrequency pulses so that your protons all align and spin in the same way. And after I give a radiofrequency pulse, I can wait a little while. And when your nuclei return to their original state, they emit a little bit of radiofrequency signal that I can actually detect. So this is a strong magnetic field. So this is the MRI scanner. And just to show the magnetic field, here we've got a pair of scissors on a string. And as we move those scissors around, you can see how the magnetic field goes around the scanner, and it actually loops around the outside and goes in. And we'll hear more about MRI physics later. But the important thing is all the metal that we use all the time. So here's a pair of scissors flying into an MRI scanner. Now you see it not only goes in, but you see how the scissors start to spin. So we have this magnetic field in the MRI scanner. MRI scanners are big, dangerous things. Anything that we bring in that is metal may get pulled into that MRI scanner. And it's not like on TV or in the movies. MRI scanners are always on. They are on all the time. All the stuff that we use in medicine, like stethoscopes. If you walk into the room of an MRI scanner with a stethoscope, that can get pulled in. If you forget you have scissors in your pocket, those can get pulled into the MRI scanner. We think about all the things we use, like ventilators or IV poles. If we walk into the room with an IV pole, and that's metal, it may get pulled into the room. So you can see all this red tape that's around this IV pole. That's telling us that that's not safe to go in the scanner. You can see how this pole is getting pulled out of his hands into the MRI scanner. So we had an MRI scanner we tried to sell or take apart, but nobody would buy it. So we spent a weekend having fun with it. I mean, doing important research. The most important things here is oxygen tanks. Those are extremely dangerous in the MRI scanner. So you can see here this oxygen tank going from 0 to 40 miles an hour. It crushes this watermelon, crushes this bottom cinder block, and then you'll notice it actually comes back and crushes this top cinder block. So just like those scissors going back and forth, and this is a piece that was lodged in the wall way behind it. So the MRI scanners are very dangerous things all the time, and they're always on. That's a big deal for us in medicine. Why is that important? Well, everybody needs to know that. This is our two MRI scanners that are behind the ER. This guy thinks he's helping by bringing the bed in the room. Well, you don't bring the bed in the room. The bed on the MRI scanner is actually detachable, and the bed got pulled out of his hand and jammed up against our MRI tech. Here's the view in the room. This is an MRI scanner. He's taking the patient up. This bed is detachable. He doesn't know that this guy who thinks he's helping is bringing the bed in. The bed gets pulled out of his hand and slams up against the MRI tech that's being pulled into the scanner. So we need to be very careful all the time about all this stuff that's in the room. Is this metal? Is it safe to go in there? Because this scanner is on all the time. It's a huge magnetic field, way stronger than the Earth's magnetic field. So we want to be very careful about that. It will erase your credit cards. It'll, pull your watch off. It's very big deal. Now,
Is there a reason why it's on all the time? Oh, sorry.
That's all right.
Is there a reason why it's, yeah, is there a reason why the MRI scanner is left on all the time? Like, why don't we just turn it off?
Yeah, it's a very complicated magnetic field. It's actually not easy to turn on or off. We have a director of MRI, Ulrich Rasner, who I think is going to give you a talk in more detail about that. But it's not like on TV or in movies. That scanner is on all the time. It's on 24/7. So, the guy with that big sweeper who's cleaning the floor around the hospital at 2 a.m., if he goes in the room, that thing will get pulled right out of his hand. The guys who are running around with that crash cart, like they're auto mechanics who are running to a code, if they push that cart in the room, it'll get pulled right into the MRI scanner. And you can imagine if there's a patient in the scanner at that time, that is a big deal. So it's actually extremely complicated to turn on and off the magnetic field and to get it uniform. So for example, in this image, this is kind of a conglomerate putting together a bunch of pictures, but the brain is very different than the chest, is very different than the bowel, is very different than the bones. So we want that MRI field to be uniform so that we get nice, clean pictures for everybody when they're trying to take care of their patients. And that uniformity is not an easy thing to do with shimming the magnet. And I think you'll hear more about that later. But we can get pretty good pictures like of the knee. So where the femur and the tibia meet, where that meniscus is, the ACL and the PCL that are in between, we can see those structures very well on MRI. So MRI is great for soft tissues. We can do breast MRI. We're hoping that breast MRI will be better for breast cancer than mammography. We know that mammography is actually not that good. When you actually find a cancer on a mammography image, there was usually an abnormality on the prior. We can do a lot of body parts. So here's pubic symphysis. We see the bladder, we see the uterus, we see the vagina, we see the rectum going back, we see the sacrum, we see the very bottom of the lumbar spine. We see those structures well, but MRIs are slow. It may take 30 minutes or longer to do the study, so parts that are moving around, like the bowel, may be all blurry. So CT is very fast. I can go through your whole body in just a couple of seconds, in about 12 seconds, and make 0.4 millimeter images of your entire body, head to foot. But an MRI scanner may take a half hour to do that scan. It's a much slower modality. The other thing we have is contrast. Just like on CT, it may be hard to see metastatic disease without contrast, but if I give contrast, I can see these enhancing METs very easily in the brain. So anytime you're thinking about tumor or infection, that's when we're thinking about giving contrast on that study. And we can also, just like CT, look at the blood vessels. So here we see the aorta going down, we see the heart, we see the aorta, we see the kidneys, we see this anatomy very well. So we can manipulate the MRI image similar to the CT image to see only the blood vessels. Here's a runoff. So we see all the blood vessels going down in the legs very nicely here. Even though this picture was from about 10 years ago, we can see that anatomy very well, from the aortic arch all the way down to the toes. And we do all these images. So you see why it takes us a half hour to do an MRI of something. We talk about these different sequences. So instead of talking about density on CT, we talk about intensity on MR. This is a T1 weighted image. This is a T2 weighted image. This is a stir image. We have all these different names for them, but you see sometimes things are bright on one image and dark on another, and they may vary and be different between different studies. So when we do these reports, we sometimes talk about things. We have something at this location, and it's dark on T1, and it's bright on T2, and it's bright on stir, therefore I think it's fluid. So we can guess at pathology. So on CT, we talk about density, and on MR, we talk about intensity. So very different. Now we're getting better. We can image parts that are moving. Here's a heart beating. So we're figuring out how we can do MRIs faster and see things that are moving as they go around, but it is harder. So we don't do a lot of things like MRI of the lungs, for example, because we could make the patient hold their breath for a half hour, but it would be wrong. And we can do other parts where they're moving. So this is a very kind of rough image, but you see how the patient is flexing and extending their neck, just like in that x-ray. And we can get an idea of how those vertebral bodies relate to each other. This is another similar case we did where we gave the patient instructions to count to 20 and then flex and then count to 20 and then extend. And we realized after looking at the images that the patient was counting out loud. So we can see this anatomy very interesting in a new way. Here's the hard palate. Here's the soft palate. There's the uvula. Here's the tongue. Here's the mandible. Here's the hyoid. We can see how this anatomy moves on vocalization. So next we have nuclear medicine. So here we take a radioactive isotope and actually inject it inside the body. And then we can think about kind of putting a giant gamma detector over the body and just detecting radiation that comes off, the radioactive isotope as it releases its energy. Now we can use this kind of in physiology. This is a GI bleeding study. I had a patient who was bleeding from below and we couldn't figure out why. So we injected them with the radioisotope and we just imaged over and over again. So this is 45 minutes and this is 90 minutes. And we can see where a little area of increased uptake happened on this red blood cell tagged GI study. This is a GI bleed study. So I could go back and I could go just to this area of the bowel, right where the aortic bifurcation is. And I just took off that section of the bowel and it turns out they had a little lesion inside the bowel there. So we had done a big X-lap on this patient, opened up the bowel, but we couldn't find anything. So this was a study that helped us figure out where they were bleeding from. So that's a GI bleeding study. And if you think about the anatomy on CT, I'm looking at density, so it's sometimes hard to see things. But on nuclear medicine studies, I can see physiologic properties. So here I see this pathologic lymph node that's very hard to see on the CT. And then I can combine CT and nuclear medicine for a PET CT. So here I see this pathologic lymph node much easier here on the fused PET CT image than I see just on the CT image. So that's a very powerful tool to use together. So all these pathologic lymph nodes were hard to see on CT, but I could see them much better on the PET CT. So PET CT is an exciting tool because I see both the anatomy and the biophysical properties. And we can do a PET CT of the whole body. So there's some normal bladder uptake, but if there is pathology somewhere, I can see that very nicely quickly on a PET CT of the whole body. But again, I'm very slowly detecting that energy, so it takes a long time. So next we have ultrasound. So here we're using ultrasonic waves, echosonography, and we get these 2D images, but we can reconstruct it into fancy 3D imaging. But the basic idea is that you have a probe that's both sending out and receiving the sound waves that's connecting to a CPU that has a display. Now I can do some neat things, like I tell it, hey, make everything moving towards the detector red and everything moving away blue. So if something's vascular, I can get an idea of that on ultrasound. So here we're going to talk about echogenicity. So with something high echogenicity or low echogenicity, do we have posterior acoustic shadowing? Those are all words we use on ultrasound studies. And we can make 3D images, just like if you go to a mall somewhere and you try to get intrauterine pictures of your baby or something, you can generate those. And we can see parts that are moving. So here's a heart. We see the ventricles on top, atria on bottom, and we see these heart valves. We can do ultrasound very quickly and easily and portably just with sound waves, no radiation to try to see those structures. And we can, as computers got smarter, we can not only do the 3D kind of surface rendering, but we can also do videos to try to see things. So ultrasound has gotten much more powerful over the past couple of decades. We can do a lot more with it to try to see the anatomy. And it's great because it's so portable. You can essentially take something like a smartphone and connect a probe to it and go do an ultrasound anywhere in the world. And it's also great for interventional. So here, this is a lymph node that's in the neck. And we see the fat and the hyla is contiguous with the fat around it. But here I'm sticking a needle in the lymph node. So I'm just holding the probe in one hand and I'm holding the needle in the other. And I can quickly and easily do a biopsy here of this lymph node with multiple passes for pathology. So ultrasound's great for that. So we have all these modalities. So we think about plain film, CR, computed radiography. We have CT, computed tomography, MRI, magnetic resonance imaging, ultrasound, ultrasonography, and nuclear medicine studies. So we're thinking all the time not only about how much data we're generating with all these studies, because we need to store all of those. We used to need space. We had these huge file rooms where we kept all our hard copy films. The problem with hard copy is that you only have one copy of it. And if that copy is over at, Huntsman and you need it at the hospital, that's a big deal. But with the digital world, we can think about different things. So which of these modalities use radiation? Which is portable? Ultrasound is very portable. MRI is not very portable. You can't pick up a 3T MRI scanner and bring it anywhere. We think about anatomy as well as physiology. That's a big deal, as well as cost. How much do each of these cost? So if somebody calls up and says a story, I've got a patient with a headache, they have positive blood cultures, what kind of study should I do? We can think about that in that way. Now we have a couple of other modalities that we use that are kind of special. One is MR spectroscopy. What if I just took a square, a little three-dimensional square, 2 by 2 by 2, and you told me the ratio of all the components that were in that square? We can actually do MR spectroscopy in some cases that are complicated and see choline, creatine, and NAA and see how that changes with tumor. So with tumor, choline is high and NAA is low. So we have increased cell death and increased cell membrane turnover that tell us that this is tumor and this is normal brain by looking at the ratios of those metabolites. So that's MR spectroscopy. That's a powerful tool. We also have functional MRI, what's sometimes called BOLD imaging, B-O-L-D, blood oxygen level dependent imaging. If I tell you to get in the MRI scanner and I tell you to wiggle your left fingers, a part of your brain on the opposite side near the hand knob lights up. So we can have you do different tasks in the MRI scanner and we see oxygen increase in that level. So we see increased oxygen in different parts of the brain when they're being used. So BOLD, blood oxygen level dependent. So it takes a long time, but I could tell you to talk, I could tell you to listen, I could tell you to think about things or wiggle your fingers or do what's called finger tapping, and I see different parts of the brain light up in those cases. Another kind of imaging modality we think about is MEG. There's magnetoencephalography. So it's kind of like a giant upside down water bath. It looks like that original CT scanner. And this is like a really strong EEG, and it combines it with the anatomy. So if you think you have a relatively small 10,000 neuronal abnormal firing in the brain, sometimes we do EEGs on patients, and we think the seizures are originating in one area, but they're really originating in somewhere else. MEG scanners are more sensitive to try to do that. But again, that takes a long time to do those studies. Then to finish up, we have multimodality image fusion. So what if we can fuse these different modalities? That's a big deal. Just like we mentioned, if we have CT and we have PET, if we fuse those into PET CT, that's a great thing. What if we did the same thing with MRI? If we could fuse MRI and PET, that would be neat. We could see both the anatomy and the physiology. And registration is obviously a big deal. If I'm going after some little tiny thing, like a little tiny maybe parathyroid adenoma, I want to be exactly sure that that CT and that nuclear medicine study that might have been performed at different days exactly line up so that when I cut out that soft tissue, I know what I'm getting. So one of the biggest problems for us in radiology is data overload. When I started radiology, I was looking at about 2,000 images a day, and now I'm looking at something like 200,000 images a day, or at least before COVID I was. So we have a huge amount of data we're trying to go through, and with our strange world of reimbursement, we may be getting paid less for these studies now than we did years ago. So we're always trying to figure out in radiology how we can interpret this data set and manipulate the data set in a way to help us be most effective. So we're thinking all the time about these different reconstructions and everything else. So that's a review of radiology. I think Najat said that you guys should have all gotten the email for the quizzes. So here's your quiz. You should have all got an email with these. You can just answer, highlight, or choose what you think the answer is and email it back to them. So the first question was, which modality uses the least amount of radiation? Is that CT, PET CT, plain film ultrasound, or fluoro? Which uses the least amount of radiation? The next question is, which modality generates images the fastest? Which of these can do fastest? CT scanner, PET, functional MR, MR, or MEG? Next, which modality uses sound waves? Is that CT, PET CT, functional MR, MR, ultrasound? If you didn't get the email with the questions, just let us know and we'll have them sent to you. Which modality is the most portable? CT scanner, PET CT, functional MR, MR scanner, or ultrasound? And the last question is, which is the best for initial trauma workup of fractures? Is that a CT scanner, a PET scanner, functional MR, MEG, or ultrasound? So as quickly your questions, you should have all got an email with those. You can just choose whichever your answer is, highlight it or bold it in some way and send it back. And that's a quick review, orientation kind of to radiology, an introduction to radiology and our modalities. So Dr. Olpen has put together a great series for you guys with some of our best lectures from our different specialties. So you'll hear lectures from the MSK guys and the body guys and the chest guys and the ultrasound and modality guys. And this is a kind of a variety in a varied world. There's some places where people just do CT of the whole body. And right down the hallway, there's a guy who just does MRI of the whole body. There are places where people do everything. And there are places like us and academics who are allowed to specialize a little bit more, who maybe just do different body parts in that world. So that is a quick introduction to radiology, and I thank you very much for your attention. So we're going to try to do these talks and these lectures like this. So you should have the emails for me and Jeff and Serena, our administrative assistant, to help us with all of this. Just let us know if you have any problems. You should all have the schedule for the lectures. We're trying to record all these lectures, so if you do have a test or something else you miss it, you can watch it later. And we'll try to help you guys along as we try to do this digital rotation for you. So thank you so much for signing up and helping us run the course this year. And that will finish up my talk. See, Dr. Olpen, did you have anything else to add orientation-wise?
No, I did want to know if that was enough time for the students to be able to respond to the quiz. I just was wondering if the students, did anybody?
If they have it all in email, I thought they'd have more time.
Sorry?
If they have all the questions in email, I thought they would have more time.
Did you send them via email, the questions? Okay.
Yes, Najat said that everybody got the email.
Okay.
For the other students, emails with quiz questions went out for this lecture, Najat said. So I think everybody got the email. So I'm assuming they will have as much time as they would like with that, with that email.
Well, that's great. I hadn't have thought to, I was just going to show the initial question via PowerPoint slide. I hadn't intended to send the email, but that's great. We should send the email with the questions. That would be much smoother. Yes,
sir. I think the plan is that if we can have all the speakers get the questions in beforehand, maybe Serena can email those out the day before or the night before.
No, that's a great idea.
Send out those quiz questions with the speaker's last name, just the numbers 1 through 5 in the text box, so they can open up with those questions and read them. if you need to see them again. Question 1 was, which modality uses the least amount of radiation? Is that CT scanner, PET CT, plain film ultrasound, or fluoro? Which uses the least amount of radiation? Also, since we're recording this and we'll post it, you can all see these anytime you want. Question 2, which modality is the fastest? Is CT scanner, PET CT, functional MR, MRI scanner, MEG, which is fastest? Number 3, which modality uses sound waves? Is that A, CT scanner, B, PET CT, C, functional MR, D, MRI scanner, or E, ultrasound, which uses sound waves? Number 4 is, which is the most portable? Is that a CT scanner, a PET CT scanner, a functional MR, or an MRI scanner, or ultrasound, which is the most portable? And number 5 is, what is the best initial trauma workup for possible fractures? Is that a CT scanner, a PET scanner, a functional MR, an MEG scanner, or an ultrasound? So those are your questions. You should have all gotten that in the email, so you'll have more time to think about it.
Okay, that's great.
Great. Thank you, Dr. Olpen. Anything else for the students?
And I hope that we have Dr. Mann logged on and ready to go.
I have a question.
Sure.
So on the syllabus, it mentioned like a timestamp, like you had to turn in that quiz.
Correct.
Before the answers were gone over.
Provided.
So I was just wondering, like, when is that due then?
Well, are you still there, Dr. Wiggins?
Yes, sir.
So are you displaying your answers?
I'm not displaying the answers now. No, I think the idea is for them to fill them out. The problem is that some of you at different schedules and seat at different times. So some of you may be watching these videos later and turning in your questions when you watch the answers. So I think the plan might be to give you a little leeway about when you do that. But the idea is at the end of the talk to try to email in your answers after they're shown.
So how are we going to provide them the answers then?
I already sent the answers to you and Serena, so she knows the answers.
Okay, well, we will get the answers. We're still just kind of playing around with how to do this. What I had envisioned is that we would have the students answer in real time, and then they would send their email, and then after the emails were sent, then we would go over the answers, but we can certainly do Dr. Wiggins' method as well. Again, you'll have to be patient with us. We've never done this before. This is the very first time that we've tried anything like this, so it's a process that is evolving.
Yeah, sorry about that, guys. You'll have to give us a little leeway as well as we all navigate this. But the idea is that Serena's going to send out the quizzes either the night before or before the lecture, and you just have to choose your answer and send it back to Serena. So just reply, send it back, and she can check it with the answers, and then she will forward that to Dr. Olpen to compile everything. That's the plan right now.
Did anybody not get that email? Sounds like everybody got it.
Great.
Sorry, I have another question just related to that. So like today I have my OSCE, and so I'm going to be watching the lecture later. And so then I just watch the lecture and then send in my answers as soon as I'm done, or do I? Yeah. So I guess I'm just confused with that part.
Yeah, sorry. We didn't know that you guys had these other things going on. We thought all of you would be able to attend all the lectures. So we're going to have to be a little flexible with your time as well as ours, unfortunately. Sorry about that.
So send them in. Don't sweat the quizzes. We're not here to just fail people if they don't send in their quizzes. We would like to get the responses and to begin with too. Initially, while we're experimenting, don't sweat this if it doesn't go smoothly. Just send them in as best you can, whether you're watching this at a different time or whether you're watching this live. Just send in your quizzes when you have the opportunity. We will provide the answers either in real time during the lecture, or we'll send them to you after the fact. And we still kind of have to iron out all those bugs. But please don't sweat about, oh, they didn't get my quiz or I didn't send it in a timely manner. We're still playing around with this system. Does that answer your question?
Yes, thank you. And then do we know yet where these will be posted, the lectures? Are they going to be on Canvas or are they going to be sent
either
to
on
us?
Canvas or we'll send you information for a YouTube channel, whatever seems to be the best interface for you guys.
I actually discussed that with Sarah Lamb over the weekend, and she thought that the best place to posit the lectures would be on Canvas.
Great.
And that's probably what we'll try and do. That's going to be a little bit of an effort, and there's some logistics involved. So they may not appear, if they don't appear today, don't sweat it. They'll appear within the next couple of days. And I would strongly encourage you to view those lectures that you're missing during your examinations, if you possibly can.
Okay, so
Do
I'm
we
going
have
to
Dr.
start
Mann?
recording. I'll try to upload my talk to them, and